share a screen and pull up my slides. So give me just a second here. Okay. If one of the co-hosts would just unmute themselves for a second and let me know that you have a slide in front of you to see, so I can know that it's working.
Your PowerPoint is working.
Okay, perfect. Thank you very much.
The thumbnail.
So I'm going to leave everybody muted, but I'm going to leave lots of time for questions at the end. So if you want to write down your questions for yourself or write down your questions in the chat box. I am not able to read the chats while I've got the slides up on my end, and I can't see it. So I'm just going to dive into the program, talk about coronavirus, and then make sure I leave lots of time at the end. Everybody has sort of become their own little mini experts on this topic, but I thought what I would do is summarize really where we're at, what we know, what we don't know, and that sort of thing. And so I'm just going to systematically sort of run through this. It's now being called a pandemic. Even that term has both political and scientific issues associated with it, as does essentially everything that has to do with this virus. I'm defining the term pandemic as a disease that's prevalent all over the world. And if you've been following the news, you can see that there are areas of the world right now that are truly, suffering, while the U.S. is really coming down through the backside of it. Brazil is really having a difficult time. If you review where in the world it's really been a big problem, you will see that it's really been big cities where people lived in concentrated areas that suffered the most. So in the US, New York City, certainly areas around New York City, Boston, certainly had some problems earlier, Detroit. But pretty much everywhere in the US now, the number of cases is on the decline. It's going to be interesting to see what happens in the next 10 days with all the social unrest and unsafe behaviors from a public health perspective of the demonstrations and the like. The virus is not gone. It's not gone, as I'll tell you about, locally or really anywhere else, but it is reduced in numbers to hopefully what will be a manageable level. You'll remember that the original theory and why we allowed our rights to be taken away was this so-called flattening of the curve, with the fear being, with the models that were presented early on, which have turned out to be widely inaccurate, but the theory being that this would be such a massive and horrific infectious disease issue that we would greatly overwhelm our healthcare delivery system and be unable to take care of people. The reality is that that has not happened. Even in places like New York, where the system was taxed for short periods of time, the healthcare delivery system was adequate to deal with the problem and will be adequate going forward. So even though I do expect that there will be small clusters of infection going forward, hopefully we know enough about it now that we won't tolerate going backwards from our phase 2 to phase 1, although the public health people will wish to remind us that that is always a possibility. Where did this virus originate? Well, it clearly does appear to have originated in China. There has been speculation that it came to the US earlier than the public health system recognized. And indeed, it looks like the earliest known cases probably came through the Silicon Valley area of California before they were recognized in Washington. So it did originate in China. The source of the infection remains unclear and controversial. The Chinese want you to believe that it happened through an animal vector. And we know that coronaviruses are present in the animal world. They have been identified in bats. And so bat soup was one of the early thoughts. Birds also do carry coronaviruses. It does appear that it probably did originate in the Wuhan area of China. There is, as has been well publicized, a weapons research facility there that the US has participated in and China runs. And whether or not that played a role in it remains unclear. One of the things that is definitely clear is that China has been less than forthcoming about what they know about it. So I would say that at present time, we really don't know the source. As far as how transmission goes, there's been lots of theory, but the reality is this is a virus that's spread by respiratory droplets. That means it leaves somebody's mouth or nose in small droplets, goes from one person to another person. Although there have been theoretical statements that it can be spread from person to person by other than respiratory droplets, it's very much unproven at this point in time. And I think that the bottom line is going to ultimately be that this is a droplet-associated respiratory virus, much like influenza and like the other coronaviruses. So as far as whether or not you can culture the virus from surfaces, you can. Whether or not anybody is catching the virus from surfaces is controversial and unproven. Even though there are animal vectors, whether people can get it from animals still remains unproven. And if it happens very infrequently. And recently there's been some discussion about blood-to-blood transmission, and I think that will prove to be untrue. I think that the blood delivery system, the blood donation system, is not a risk factor for spreading this. The virus, to my knowledge, does not live in the bloodstream and cannot be transmitted from one person to another person via blood or other contact. The disease, when it occurs from person to person, goes from the droplets containing respiratory virus to inhaled by the victim. The virus then binds to viral binding sites on respiratory epithelial cells in the lungs and can form a pneumonia-like picture if the person is going to become symptomatic. For most people, they'll either be asymptomatic or they'll develop a respiratory type of an infection. If they get a respiratory type of infection, most people have a relatively mild respiratory infection, which is essentially indistinguishable from influenza and other coronaviruses. Coronaviruses are not new to us. Coronaviruses have been a source of the common cold and our seasonal viral respiratory illnesses for years. What is new is that this specific strain of coronavirus is new and in the wrong immune system can be pretty devastating. In people who get a more advanced form of the disease, it usually progresses from pneumonia to a more widespread pneumonia, can form something called shock lung, which is also referred to as adult respiratory distress syndrome, where the immune system overreacts, and it can be a pretty devastating and overwhelming respiratory type infection. The pathophysiology is thought to invoke something called cytokine storm, where basically the immune system overreacts and can set off a cascade of problems for the victim. In people who get sick, it can then spread to other organs. It doesn't commonly do this, but in somebody who becomes really overwhelmed, whose immune system is not getting the virus under control, it can lead to infection of the liver, kidneys, brain, and other organs, and ultimately wind up causing multi-organ failure. In the small number of people who actually die of viral-related disease, it can be very difficult to treat. The reality is that most people who die with the virus are dying with the virus rather than from the virus. And there hasn't been a lot of distinction between those sorts of events. The treatment for the virus is that we don't have any sort of a direct cure. So what we do is symptomatic treatment, treating either their immune system if it's overreacting, their respiratory system if it's not actively, accurately oxygenating. Basically, it's on a patient-by-patient basis, relying upon the patient's immune system to basically ultimately get the virus under control. Early on, there was a lot of talk about putting patients on respirators, and what we found is that respirators probably caused more damage than they did good on patients who ultimately must have it because they can't oxygenate themselves. We found that using respirators differently than conventional use of respirators was helpful. We use them most effectively when they're in the sort of use like people that use CPAP machines, positive pressure airway sorts of things that people with sleep apnea would be familiar with, where you've got the ability to positive pressure ventilate somebody rather than putting them on a more conventional type of a respirator. The people who die have been really confined, for the most part, with rare exceptions, to people whose immune systems are non-functional or overreactive, or who are immunocompromised by age. So as I'll show you in the slides later on, the people who die are really a select group. The people who get infected are interesting. It looks like the very young either don't get infected, or if they do get infected, remain asymptomatic in their infection. And I think that they just, for the most part, are not getting infected. We're seeing more viral antigen positive tests in young adults than we had previously. And that's largely because we're testing more of them now than we did. There clearly are asymptomatic carriers, and whether or not you are infectious as an asymptomatic carrier remains debatable. An epidemiologist with the World Health Organization a couple days ago stated fairly strongly, based upon, I think, pretty good evidence, that spread of individuals who are asymptomatic to people who become infected from that exposure is probably a pretty rare event if it's happening at all. And I think that's probably going to turn out to be true. When we can go backwards and look at people who become infected, we generally can find somebody who they were exposed to who was indeed symptomatic. The incubation period for this virus averages about 7 days. Some people will show up with infections closer to 5 days. There are rare people that have gone over a week into the second week. We think that if you've gone 2 weeks, that's the 14-day incubation, period that we quarantine on the basis of that you're not going to be infected if you were exposed. One of the things that we've learned from how we've treated the virus is that the concentration of virus that you're exposed to is probably important. The reason that New York City got hit so hard is that people were getting exposed in high concentration settings. For example, if you think about being on a subway where people are packed in like sardines, and somebody on the subway is infected and is coughing or aerosolizing droplets, they're going to have a large amount of virus released in a small amount of space. And in people who are susceptible, that's giving them a high viral load of infection. When people are exposed to a lower viral load of infection, if they become infected, their infection tends to be less significant, less severe than when they're exposed to a high viral load. And that's part of the reason to recommend that people wear masks. It's not that the mask is stopping all droplets from being able to be transmitted. It's that it's shortening the distance of transmission, and it's lowering the number of droplets that are being spread, so that if you do get infected by somebody who is infectious, that you're getting a lower viral infection. and that you'll have hopefully a lesser disease, if you will. And this has come up in some of the things that you hear about all the time on the news. Like there are some medications that if patients are on them, it seems that they either don't get infected, or if they do get infected, get a lower level of viral infection. And those are specifically people who have high blood pressure, like me, that are on either angiotensin converting enzyme type medication, or another class of high blood pressure medication, the AIBs, of which losartan is sort of the most common drug. And it's really fascinating. And in that, what it looks like is happening is that those blood pressure medicines bind to the same sites on the respiratory epithelial cells of the lungs that the virus binds to. And so it's cutting down the number of available viral binding sites, leading toward either the virus being blocked, or if the virus gets a hold of the epithelial cells, it's getting a hold of them in much lower viral concentration. So I think that we're on to something there. And what's kind of fascinating is if you're on one of those medications, particularly the angiotensin converting enzyme, like lisinopril is kind of the class that most people have been familiar with, it's associated with a chronic low-grade dry cough. And that dry cough is very similar to what patients who have coronavirus have in terms of their cough. It tends to not be a mucousy, kind of a wet deal. It's kind of a dry kind of a cough, which is, I think, fascinating. Some lessons that we've learned so far, in addition to what I was talking about, is that you don't want people to be concentrated together in a setting where they can be exposed to somebody that's infected in a closed space. You don't want people whose immune systems are weak or who are elderly getting exposed to large concentrations of the virus all in one time. So it makes much more sense to protect people who are at risk, not of becoming infected necessarily, but of becoming quite sick. So the idea of quarantining the population rather than quarantining individuals who are at risk is probably not how we should have looked at this. But remember, the goal wasn't to keep people from becoming infected. If we want to ultimately get beyond this coronavirus pandemic, there's really two ways to do it. They are to get enough people infected that they have become immune after they've come through the infection, or to create a vaccine where people are protected by the vaccine. One way or the other, or together, they develop something called herd immunity, where the herd is enough people are protected against the virus that the spread of the virus slows down to the point where less than one person becomes infected by one person who is infected, and that's when the disease goes away. One of the things that we know about coronaviruses from previous experience with common colds is that they are susceptible to UV light. And so as weather gets better and there's more sunshine, UV light kills the virus. It's really fascinating. If you go back to the influenza virus of the Spanish flu, the 1917 pandemic, the treatment, and by the way, Bellingham was relatively hit hard in that epidemic. The treatment was to take people who were sick outside and allow them to be exposed to fresh air and also to sunlight. And it does look like, I think that there's something onto that. I think that we can expect that the virus is going to drop in numbers through the late spring and summer months and fall months. And we're going to be at risk again if we haven't developed a significant herd immunity over time to the virus coming back in the late fall and winter of next year. So what can we do about it? Well, you've heard about hand washing, so you're probably sick to death about hearing about it. But the idea is if you get those droplets on your hands and then you get your hands to your face, that you can transmit the virus in that manner. So hand washing, good thing. Masks are controversial. I think that the current craze of wearing masks does more to lower people's panic levels than it does to really get the virus under control. But there is one study which was printed in Lancet just in the last week that shows there may be something like a 75% reduction in viral spread if you are wearing these, cloth type masks, which do not stop the virus from passing through and do not protect you from inhaling the virus, but they do keep your hands away from your face. They probably do shorten the distance of droplet spread. And, they're not an unreasonable thing to do. Quarantine is still, what you want to do if you've got somebody who is infected. And so, I'm not going to spend a lot of time talking about that. Prophylaxis is something that got a lot of play because President Trump took chloroquine, which is a medicine that has been available for a long time. It was an anti-malarial drug originally, but it's used today in medicine more for patients that have autoimmune diseases like lupus. And whether or not it's effective as a prophylactic agent is very controversial. Lancet published a study showing that it was contraindicated, didn't work, shouldn't be used. And then just in the last few days, the authors of that study, when it came to their attention that the data they published was absolutely containing errors and flawed, the authors backed away and Lancet had to do a retraction. And so what I can tell you right now is whether or not chloroquine works as a prophylactic agent is unproven, still remains possible. Now, the other thing I can tell you is that doctors used chloroquine on patients who were quite sick when we were dealing with the peak and patients who had respiratory type illnesses. And early on, it had a great deal of promise. It does look like it really helped people when they were at their sickest. The problem is that the chloroquine is not without side effects and problems of its own. And when it continued to be used, patients wound up getting sicker from the side effects of the drug than they were from the virus. And it often had to be stopped. So it is not a cure-all, it is not a cure. It's not good in everybody, and whether it works in prophylaxis is yet to be determined. But it certainly got a lot of play from a public relations standpoint when Trump was taking it and believed in it. I've already talked about ventilators. I can tell you that in Whatcom County, we have not had a patient on a ventilator due to COVID-related disease in over 6 weeks, probably closer to 2 months. We have still had patients who have died. So how are they dying if they're not dying on ventilators? They're people who were very sick to begin with that either were not going to allow themselves to be put on ventilators or, who died without going to the ICU or being put on a ventilator. So the patients who are dying in our community are not patients who are in the hospital on ventilators or in the ICU. They're patients who are old, infirm, have multiple comorbidities, and are dying either with the disease or from the disease. The reason that there is controversy, and I'll tell you, you really cannot believe any of the numbers that have been released, is that there is no uniformity in how the reporting is being done. For a while in Washington State, and I'm not totally convinced that it's changed, because COVID testing is a reportable event to the public health department, the state was cross-linking anybody who died to anybody who had had a COVID test done, regardless of the interval between when the test was done with a positive result and when they died. And they were counting anybody who died with a COVID positive test to be a COVID-related death. And when those death certificates were reviewed, things like, for example, George Floyd, had he been in Whatcom County, would have been counted as a COVID-related death because he is COVID antigen positive per his autopsy report. and clearly did not die of anything having to do with COVID-related disease. I do not have the opportunity to oversee or change the death certificates because the medical examiner does not have access to natural deaths that have a healthcare provider of record. So early on, when we were getting, these news reports that people were dying, and I'm saying, wait a second, I'm not aware of these deaths. I actually got my hands on a number of the cases that had been reported as COVID-related deaths, and I can tell you that they weren't. There were patients that were in terminal stages of cancer who were on hospice and in the nursing homes where the virus was present in the nursing homes, and they had a positive test result, and they were counted as COVID-related deaths. I cannot tell you how many patients have really died of the virus, but I can tell you it's a fraction of the number that are being reported to have died from the virus. The vaccine and when it's going to become available is yet to be proven. Historically, vaccines have taken on the order of 10 years from inception to production. We're now thinking that we're going to be able to do it in 1 year or less. There are a number of promising vaccines that are in the animal stages, some in the early human testing stages, and we're doing this more rapidly than has ever been done before. We're throwing enormous amounts of money at it. There are going to be, winners and losers in this battle. On NPR today, they were talking about a company that has hundreds of millions of dollars being thrown into ramping up production so that when we have a vaccine, they can produce it in the millions of doses that'll be necessary to do it. When you're creating a vaccine this rapidly with this little testing, I am really worried about vaccine-related damage. Vaccines are not always a good thing. Recognize that there are global health issues. Bill Gates has controversially been very involved in this pandemic, and not always from a perspective that I think is necessarily in our own best interests. And geopolitics certainly is at work. Talking about the diagnosis and reporting, this virus is an RNA retrovirus, which means the virus itself has no ability to cause disease. What it does when it gains access to a binding site on the respiratory epithelial cells is it gets taken into the cell, hijacks the genetic machinery of the cell to convert it from an RNA retrovirus into a DNA form that can be replicated and then converted back into RNA as a retrovirus to get back out. So it's an interesting virus. This was covered, the idea of RNA retroviruses, really well in a PBS show that was on genetics that I recommend if you're looking for more about retroviruses. All of the coronaviruses as a group are retroviruses. Coronaviruses and adenoviruses are the two major causes of common colds. So you have all had, everybody that's listening to me has had coronaviruses in the past. How many of you have had this coronavirus remains an unknown. In cities where they've done widespread antibody testing, specifically the Palo Alto area, the Silicon Valley area, San Francisco, New York City, and Detroit, it looks like somewhere between 10 and 30% of the population has had the virus and has developed antibodies against the virus. And I'll talk more about that. In terms of the test, basically, you need to understand that there are two different sorts of tests. There are antigen tests, which are tests against the virus, and there are antibody tests, which is looking for the immune response to the virus. They are neither the antigen test or the antibody test are particularly great tests. Part of the reason that there's been so much confusion about the testing is that there's an expectation that if you have a test, that it'll be a good test. And the reality is it's never that simple. In order for a test to be a good test, you need to know information that we still don't know, which is what is the percentage of the population that has the disease. So I'm going to give you just a really quick 101 level laboratory medicine lecture about the statistics of the test itself. Tests all have something called sensitivity, specificity, and predictive value. The sensitivity of a test is what is the probability that if you have a positive test result, that you have the disease. So if you're generating a test, and recognize this virus wasn't on anybody's radar before February. So we were able to come up with a test in absolutely record time, but we weren't necessarily able to come up with a good test. So what you want is a test that has a high sensitivity. If you've got a high sensitivity, that means that you're willing to accept a relatively large number of false positives. Because if you have, let's say, 100 people that have the virus, and you want 100 of them out of 100 of them to have a positive test result, you've got to design a test that's willing to accept that there's a substantial number of people who have a positive test result but do not have the disease. It would not be unusual, and for example, when we first came up with HIV tests, it was not unusual to have more false positives than true positives. So a test that has a high sensitivity alone is not adequate. So the second thing you need to know about the test is what is the specificity. The specificity is the probability that if you have a negative test result, that you don't have the disease. Now you can come up with a test that has a high specificity, but you would sacrifice, again, people who would be missed because, having a negative test result and not having the disease, you could be missing lots of patients that way too. So the way we deal with this with HIV testing is that we do two tests. We do a test to start with that has a high sensitivity, and then we do a confirmatory test that has a high specificity. If you flunk both, the likelihood that you have the infection is high. But that's not how we're handling the test right now. What we're doing is we're trying to develop a test looking specifically for this RNA type virus that is supposed to do both. And it's just not possible. So we don't know what the sensitivity of the test is. What we do know is that there are people who clearly have the virus who have a negative test result. So it's not perfect. And there are patients that have been tested serially over time that we believe have the virus, who are negative at one point in time, become positive later on, and then become negative after that. So, the way we've dealt with that is that we're treating people's symptoms as well as treating the test results and making very big decisions based upon an imperfect test, if you would. So it's led to a lot of chaos. And the government has, made this worse by saying, well, we'll get control over this thing when we just have widespread testing. And the reality is that just has not happened. It's not happened for a number of reasons. It's not happened because there isn't just one viral test. There isn't just one antibody test. There are a number of them, and they each have their own pluses and their own minuses, and you don't know which test you're being tested with. Locally, we had a large number of bad results, both false positives and false negatives, with the tests that were being put out by the large laboratories like Abbott and Quest. And then when the local pathology group started doing a much higher quality test, we got better test results. And so right now, when it's coming out of Northwest Laboratory, you get a much more reliable test, but it's still not a perfect test. The bad news for the Northwest pathology test is it's about a $180 test. It's not one that we can do in large numbers. It's not one that we can go out into the community and test large numbers of people with. So the bottom line is the laboratory medicine part of this thing has been confusing and imperfect. What we really want is a really good antibody test. And that's just still not available. I have in my office an antibody test kit that I was able to get my hands on. Unfortunately, it's made in China. And even though it probably has more experience than a lot of the other antibody tests, it did not pass FDA approval, I think politically, because it came from China. So we don't really know how good it is. We don't really know how good any of the tests are right now. When we have an antibody test that we can rely upon, and we're not there yet, it's going to be looking for two things. It's going to be looking for production of IgM, which is an acute phase reaction that people's immune system can generate after they've been infected. And then over time, conversion to IgG, which is the long-term form of immunoglobulin that gives, for other diseases, lifelong immunity. So one of the questions that's come up is, if you've been infected and you've developed an antibody, are you immune and will you have lifelong immunity? And we don't know the answer to that, but probably yes. For other viruses, that has been the case. For other coronaviruses, that has been the case. When it has not been the case has been when the virus mutates to a form that that antibody no longer fights against, and you become not immune. And where we see that, and where it's scary in this regard, is in influenza, where last year's influenza vaccine is probably not good against this year's influenza. What we know about influenza is that it mutates far, far more rapidly, at least 10 times more rapidly than coronavirus does. I would tell you that from what I know about immunology and coronavirus, that I think that once you become immune, at least for a substantial period of time, that immunity is going to be good. China released some numbers several weeks ago of patients that they claimed had been infected, got well, and got reinfected. They've subsequently retracted those studies, and there's no good evidence of anybody who's been infected becoming reinfected. And remember, when we're talking about antigen tests, antibody tests, and down the road, vaccines, there are going to be winners and losers. There's going to be political pressure. There's a lot of money involved in this. Just, be careful. The science of this is just not that great. So now let's switch gears and talk about what's going on locally and in the state of Washington. This is the most recent map that looks at all of the counties. It's being looked at county by county. I can tell you that the governor has had a very heavy hand in determining how we are going to respond to the virus. He's claimed that it's scientific based, and he has good public health and immunology people that he can draw upon, but the actual data on which the decision making has been made has never been made public and has not been very transparent. So what I can tell you is, what is it that we know? What is the data that's available? How can you look at the numbers so that you can make your own decision? Because I hope ultimately we will revert back into a decision-making mode where individuals can decide how much risk are they willing to take based upon real information, rather than having that decision be made for us on a public health, more global perspective. So Whatcom County, up at the top of the map, is in now phase 2. If I had given you this lecture 2 weeks ago, based upon the requirements for going from phase 1 to phase 2, I would have told you we would have never made phase 2. And the reason is that the criteria in terms of the number of cases over a 2-week period is so close to what I think the false positive rate of the testing is, that if you increase the number of people who are being tested, you're going to have a number of people that are going to fail the test who are not truly infected that would have kept us from going from phase 1 to phase 2. How did we deal with that? ultimately, under political pressure, Inslee moved the goalpost. And a week ago Friday, he basically said, okay, it's not going to be this number over a 2-week period of people based upon 100,000 population. It's going to be this number. And that just magically allowed us to, with nothing different that we were doing, go from being phase 1 to being phase 2. You can see that there are still some counties that remain in phase 1. King has gone to 1.5. Yakima still has a problem in terms of number of cases. Yakima, Benton, Franklin, Douglas, and Chelan have not moved to phase 2. A number of counties have now moved to phase 3. You've got to be in phase 2, and now we're in phase 2, for a minimum of 3 weeks and to meet a bunch of other criteria before you can be considered to go to phase 3. And then you have to make that application to Inslee and the Department of Public Health, who get to decide whether, in the good of their heart, they're going to allow you to go to phase 3 or not. Based upon the continued level of cases that are going on and the fact that we are going to have increased numbers of little pockets of disease, it's not going to overwhelm our public health system. It is certainly not going to overwhelm our hospital, but we're going to have those cases. Unless he changes the criteria from going from phase 2 to phase 3, I think it's highly unlikely that we're going to move from phase 2 to phase 3 in 3 weeks. What does it mean to be in phase 2? It means that in small social gatherings, you're allowed to have 5 people together in a week who you don't live with. I can tell you that this is not what's actually happening. People are getting together in larger numbers. And I admitted earlier, before this meeting started, that I met on a homicide case that's going to trial here sometime soon with the attorneys for the prosecution and the defense. And it turns out there are 2 defendants who each had their own attorneys, and the prosecutor had their attorneys, and they had their investigators, such that there were 10 people that were in my meeting. I thought we were intelligent and distanced ourselves and acted in a responsible manner. However, my office is in the public health department building, and the public health people filed a formal complaint without speaking to me and sent it on to the county executive. And I was reprimanded for not setting a very good example because I had more than 5 people in my meeting. I can tell you anybody who's been participating in any of the demonstrations is certainly not doing that. And there was a meme going around that, it was these social distancing requirements applied to anybody except those who were engaged in an activity that was politically being encouraged. So I think there's some truth to that. I'm worried that we are going to see a spike in people who come down with the virus because of the demonstrations. We supposedly had 5,000 people, and I was watching this being live streamed, and a substantial number of them were not exercising the quote, minimum distances and all of that sort of stuff. So we'll see. We've got a widespread biological experiment taking place right now. In the worst case scenario, it's not going to overwhelm our healthcare system. In the best case scenario, hopefully it'll be a small number of people, and in about a week to 10 days, we're going to know. Outdoor recreation like camping with less than 5 people is opening up again. Businesses and services, you'll notice that I was able to get a haircut yesterday. The rules that are allowing these businesses to open, are being overseen by public health people, but at least we're moving in the right direction. Restaurants can open at up to 50% capacity, but no bar seating. There has been so far no tort reform, no protection of businesses. If they are acting in good faith and somebody gets sick, they can still be sued. And how that's going to go down over time is yet to play out. But I can tell you that although it's been talked about there being some sort of a legislative, immunity, so far none has been issued. The risk assessment profile, how you get to decide whether you get to advance or not, is based upon these criteria. These are the Washington State metrics. And clearly, you know, there are goals that are being established that have not, on a statewide basis, been met. I'm going to make these slides available later on and not go through them all because I want to leave more time for questions. These are looking at the confirmed cases in Washington State. And you can see that we fall in terms of the number of confirmed cases down here, about 8th, I think, 3, 6, 8th place in number of confirmed cases, but we're higher than that in number of reported deaths. Here it says 37. It's now gone up to 38. And in the slides that follow, I'm taking these off of the Department of Health and Whatcom County's Department of Health websites. These are all published daily and they're upgraded frequently. So I would refer you to go to the Department of Health, Whatcom County, and Department of Health for the state for the numbers. And again, what I can tell you is that this number is exaggerated. At 37, now 38, it's exaggerated. What's the real number? I don't know. I don't think anybody knows. Different states are handling it differently. Different health departments are handling it differently. It's garbage in, garbage out. I believe that the number that's being reported is a maximum number. There are people who would argue that we're missing cases and that the number is really higher because people are dying at home and are not being counted. I can tell you locally, I think we're doing a pretty good job because if they're coming through my office and their death is sudden and unexpected, they're getting tested. So I think the numbers are pretty rational. This is the very latest number for Whatcom County. We were not making the target as of Friday. As of Tuesday, we are now making the target on a couple of these. Our rate is less than 25 per 100,000 per 14 days. We're making the target of how many people are getting tested. We're making the target about the ratio of people being tested. We're making the target about the number of hospital beds that are available. Okay. Again, I want to leave more time for questions, so I'm going to make available the rest of these slides. They all come off of the Department of Health stuff, and they look at specifically the number of deaths, the ratio of people who are positive to dying, the total number of people who were tested, the percentage of positive test results. This looks at where the peak was in terms of infectivity. It was here, but you can see we still have numbers that are being confirmed here. The virus is not gone. This looks at the cumulative number of cases. This is when we were in the highest rate of change. Now you can see that the curve is very much flattened, and flattening the curve was the goal of all this. This is looking at it by sex. More women than men are infected. By age group, interestingly, these are the people that are at risk of dying. But recently, we're seeing larger number of people who are infected. Now that means they're antigen positive. Not necessarily that they're sick, because there's not a distinction made in this graph between people who are sick. These are people who have the test. And the more people we test, the more number are going to come up positive. So the state's using the idea that we want to test more and more people, but we're going to punish you and not let you go to a later phase if you come up with positive test results does not make sense to me. Here's the cases in terms of Whatcom County numbers that look at the age group of people who are hospitalized and the ones who die. Notice that it's the over age 80 group that are dying. Nobody under age 60 in Whatcom County has died. And when I reviewed this group of patients, I eliminated at least 4 of them that I don't believe died from COVID. So it's this group that I have not been able to get access to review that at least some of them probably did indeed die from the virus. This is looking at the number of people who are being tested versus the number of people who are positive. Note it's a very small number. It was 3.5% overall, and it's getting smaller. This is the confirmed cases per day. Note we still have cases, so this is an ongoing graph. We have not been over an average of 4 cases a day since mid-April. So we're staying below the level. I believe this is a very manageable level and ought to allow us to further open. There's been talk about whether or not there's racial disparities in COVID. I think that has to do a lot with how people are coming in contact with each other. But clearly, that's been a problem elsewhere. How about locally? Well, we're at 82%, 82% of our population is white, but 69% are the ones that have been infected. So what group has been infected disproportionately here? Well, we don't have that many blacks, so that data basically is meaningless. But where we have seen it are in Hispanics, where they're 9% of the population, but represent 23% of the people who are diseased. And with that, I'm going to stop sharing, go back to gallery view, and open it up for questions. And now I can actually look at the questions. And while you think about whether you want to ask one out loud, I'm going to go over the questions that people wrote to me and do that first.
After one.
So I'm going to let you unmute yourself in a minute, but the first question is, lisinopril is one of the medications that lowered susceptibility, at least theoretically. Lisinopril is an angiotensin converting enzyme antihypertensive. That's in that category. And that's the drug that characteristically people who take it have a dry cough, similar to, but different, but similar to that that we see in people who are infected. So lisinopril and losartan are the two class drugs that seem to lower the susceptibility. We are not advocating giving it prophylactically, but it does look like people who are on these drugs are somewhat protected. Second question is renal tropism. I'm going to leave that one alone because that's more sophisticated and probably not something everybody's going to want to hear about, but I can deal with it later after time's over. Are there any antibody tests well, I had the antibody test in my office and I took it because I wanted to be positive. I've given the antibody test to a number of people who thought they had a good story for being infected. Unfortunately, most of them thought they were infected before the disease was actually known to be in the community. None of them have been positive. I do not believe that there is currently an available antibody test in Whatcom County that I would recommend you waste your money on. I hope we're going to get one soon. I've been going week to week with my Rotary Club saying, not this week, not this week, not this week. And right now I would tell you, not this week. It's just not ready for prime time. I wish to heck it was. Next question, was St. Joe's ever overwhelmed at any point in time? The answer is they were not. We never used 1 in 10 of the ventilators that we had available. We never filled an ICU, not one day ever. Throughout this entire crisis, the hospital has had the largest number of open beds ever. They still have a large number of open beds. They weren't allowed to treat patients that had other than emergency sorts of things. They're now allowed to treat cataracts and patients with diabetes and hypertension that are not emergent and other kinds of comorbidities. I think you can make a very good argument that the people who were not treated in the hospital fared substantially worse than the ones who were treated in the hospital. The hospital has never been overwhelmed. I can also tell you that the controversy about PPE was a lot of smoke and not a lot of reality. The hospital, from my perspective, was never overwhelmed in terms of their ability to provide PPE, the personal protective equipment. There was one ER doc who was disgruntled, who complained to the media rather than dealing with the problem internally. I am not in general a huge fan of St. Joseph's Hospital, as those of you that know me will attest. But I can tell you they've handled this well under the restrictions that they've been placed under, and they have never been even close to being overwhelmed. More of my colleagues were underemployed, some of them vastly underemployed through this crisis because they were not allowed to treat patients. We have never been overwhelmed. Is it reasonable to ask the county executive and governor to open up faster? From my perspective, it absolutely is. The idea of contact tracing scares the hell out of me. The idea that we can train lay people to identify somebody that's been positive and then trust them to identify individual members, and then have those individual members lose their freedom as they are quarantined against their will or forced to isolate, scares the hell out of me. I am not personally really a fan of this contact tracing concept. So I'm not really enthusiastic about that. I think we should all be asking our county executive and governor to open faster. I think the places that have opened have paved the way to show that, we're just, more people may get sick, more people may die, but, we can control this. I think people ought to be allowed to make individual decisions. I think that the consequences of social isolation, from my perspective as the medical examiner, have vastly been a greater problem than the virus has been in this community. So I'm not autopsying a lot of people that are showing up with COVID-related disease that was unexpected. I am autopsying increased numbers of people that are dying of drug overdoses, complications of alcoholism, complications of untreated or undertreated hypertension, diabetes, congestive heart failure. Those things all have real consequences too. And so, yes, I think it's absolutely reasonable to be pushing our public officials to be opening faster. A really great question: have we seen a problem with our homeless population? And we have not. I would have predicted, because they never socially isolated well, they never followed the rules, that we should have large numbers of sick people amongst our homeless population, and we don't. And the reason for that is unknown and unproven. But I've got a buddy named Fari, who's from Turkey originally. Many of you may know him. And he said, well, the reason for my not getting sick, the reason I never get sick, I never get common colds, I never get the flu, is that when I was growing up, we swam in sewage-infested water. We didn't have clean air. We didn't have clean water. Our immune systems were stimulated all of the time. And I think there's truth in that. I think the fact that our homeless population basically gets exposed to a whole lot more crap than the more protected of us probably is leading them to greater protection against this virus. But that is completely speculative opinion and not based on any studies that I've read. But the answer is, not only do we not have a terrible problem in our homeless population, but other places haven't either. There have been isolated pockets, some in Seattle, some elsewhere, where people are living in really tight concentrations that have seen some clusters of homeless people infected. But from Whatcom County's perspective, it has just been a non-issue. The relationship between zinc and hydrochloroquine and other things is theoretical, but we take zinc as an antiviral. Have done that, against other coronaviruses and adenoviruses. Personally, I think it's harmless. I don't see a downside to doing it. I can't tell you that it necessarily works. As far as chloroquine goes, it's not widely available. For a while, patients that really needed it, like patients that had lupus, couldn't get it. Now they're able to get it again, but it's just not widely available as a prophylactic agent. So I don't recommend that you use chloroquine until it's better proven, because it really does have significant side effects. But if you want to take zinc, I don't think it's a bad idea. Again, I think that's a personal preference kind of thing. Am I seeing an uptick in drug overdoses? Absolutely. Let me give you a great example. Last week, the Lummi Nation gave $1,800 checks to all of their tribal members, and within 48 hours, we had 2 deaths and a large number of overdoses. They took them, people on the tribe took the money, bought drugs that they didn't have the money for, overdosed, and filled the emergency room, and a couple of them died. Consequences of social isolation are real. Our numbers are too small to actually, be able to show a trend. But in talking to my colleagues across the country, I think ultimately we're going to be able to show that there have been an increased number of suicides. There's been an increased number of overdoses. increased number of complications of social isolation. But, you know, can we prove it? There's a study that came out today that looked at the relative number of deaths that have occurred over the baseline population, looking worldwide, and how the coronavirus has behaved compared to influenza and other things that have elevated above the baseline. And I think that we can say pretty much definitively the coronavirus pandemic was real. It did cause an increased number of people to die. It's selective to the elderly and the immunocompromised, but it's knocked people out, particularly in the big cities, Paris, London, New York City, Rio de Janeiro, in places where it's basically taken a greater percentage of the 80 and over crowd that had other comorbidities who were otherwise already weakened. I looked at many cases, those that passed away and were classified, not many. I was able to look at selective numbers early on. I've had resistance from the health department to review cases in which I don't have clear-cut legal authority. And so I have not been able to systematically review the files of the cases. And then when I thought I had some traction to be able to do that, Brin and Fauci went public saying that they wanted people to be identified as dying if they were test antigen positive, regardless of their comorbidities. So I lost any traction that I might have had to be able to look more critically and to take a more critical eye in terms of declaring whether patients who died with the virus died from the virus. And unfortunately, there's precedent for this. When when there's a hurricane or a tornado, they count cases of people dying from the hurricane and the tornado who didn't die from, the glass breaking or a limb falling on their head, but, who died, from some sort of complication later on. And so I believe that basically the idea of using death certificates as a way of monitoring the public health crisis is at best weak and at worst fraudulent. And I think that went through the questions that you wrote down. So why don't I open it up? If you'd like to unmute yourself and ask a question, I still have about 5 or 6 more minutes before we're out of time. Anybody?
Gary,
Hi, Lisa.
hi. Would you talk about the strange phenomenon of blood clotting that has been observed in people who have been severely impacted?
It's controversial. And I'm not sure it's going to stand up over time. But there's a very strong historical relationship between what I call shock lung, otherwise referred to as adult respiratory distress syndrome, and intravascular clotting, regardless of whether it's from COVID or from any of the other many things that cause ARDS. Whether or not this is going to pan out to be a consistent finding or not is still unproven. But I'm looking at cases of somebody that might have deep venous thrombosis, somebody who has thrombophlebitis that let's say dies of pulmonary thromboembolism, and whether or not they might have a hypercoagulable state that's responsible for it. And I personally have not seen it. I think it's controversial among my colleagues. It's as present, reported and unproven, but something that we're looking for. Now, if you develop ARDS, you definitely have a hypercoagulable state and you have an increased risk of thromboembolism and the like. So is it causal or is it effect is yet to be proven? I'm not sure I explained that very well, but you can get ARDS, let's say from sepsis, and you have that same probability of having blood vessels with clots in it as you would if you had COVID. And whether it's going to be significantly higher in COVID or not over time remains to be proven. But if you take all of the patients who are really sick and you look for a hypercoagulable state, they definitely statistically do. However, they already have some form of ARDS also. So I'm not convinced it's causal.
Can I ask a question, maybe changes the topic? Have you seen any conflicts in the reports that you've seen on the death of George Floyd?
Yes, and if you'd like the autopsy report, I have the autopsy report.
I'm just
It's
wondering quickly if there's something you might point out, because what I've heard, it sounds like there's some difference of opinions.
Well, I don't have anything that's going to take away the video that shows the knee on the neck inappropriately and for a sustained period of time. But the autopsy report, in addition to that, shows no structural anatomical abnormality from the traumatic asphyxia, and it doesn't have to. So there's no crushing, there's no injury anatomically abnormal at the autopsy. The autopsy was done by a very, very good forensic pathologist that I've known for a long time, a very competent guy. The idea that the second autopsy somehow is better than the first is nonsense. But the first autopsy does attribute the death to traumatic asphyxia based upon the video and not the autopsy findings. It also reports that he was under the influence of fentanyl, methamphetamine, and marijuana at the time of his death. Fentanyl is a very potent opiate, methamphetamine you know about. And he also was COVID positive. He was not a healthy guy. He had bad atherosclerotic cardiovascular disease. He had multiple vessels that were clotted. He had significant comorbidities. If you took away all the video of the knee on the neck, we wouldn't be having this conversation. But that video is pretty damning.
Hey, Gary, I have a question for you on your confidence in the organization, WHO, World Health Organization. They've had retractions. They make statements. They retraction. We've seen it with Lancet. You mentioned one yourself. I'm getting concerned as we try to find out what's going on, as if you have that confidence as an organization, if the WHO is the one that's going to help us in the future.
Yeah. I don't have that confidence in any organization right now, honestly. We are living in a different era than we have ever lived before, in that every piece of news, no matter how worthy or unworthy, has a camera in front of it and is going to be broadcast, worldwide immediately. I mean, if I could tell you to do one thing, it would be to tell everybody to turn off their damn television sets, because the information that's coming out right now is not reliable from anywhere, anyone. And, you just have to see over time what is panning out to be, consistent and reliable to become reliable. I have had experience with WHO personally for my entire career. They sent me to Portugal and Spain on a WHO grant to study abortion and contraception in post-revolution Portugal when I was a college student. I think historically it's been an excellent organization. Yes, it's infiltrated by the Chinese. Yes, there are political issues of any organization. The CDC is a political organization. The NIH is a political organization. WHO is a political organization. NASA is a political organization. There is no such thing right now as a lily white, clean. There's no news organization. There's no political organization. Nobody is beyond reproach. And what happened historically was you waited until enough papers got published that you could start to do meta-analysis and you could start to make sense out of it. Now every single study gets active attention, and so I think you can't believe anything right now when it first comes out. So I don't think the WHO is a bad organization. I don't think they're necessarily the end-all good organization either. I don't think that Trump's team of public health officials, is something that I believe everything that they say. Clearly, they've said something one day and taken it back the next day. I think everybody's trying to do their best. I think the real question boils down to, what sort of a society do we want to live in? Do we want a nanny, society where people have the ability to decide what's in your best interest? Or do we allow people to make the best informed decision they can on the information that's available, or do we believe that when something bad happens, somebody else is responsible for it happening? So those are big questions that are really playing out in a time I never believed we'd live in. I mean, if you wrote a book over what's happened in the last 3 months and you published it 2 years ago, it probably never would have sold, because people would have said, that is just ridiculous. There is no way in the world that you could have that sort of scenario play out. And yet we have lived, and are living through that. I think that people really are acting, with best interests at heart, but there are consequences to decisions. And when you put politicians in charge of healthcare decision making, it's an invitation for disaster, and I think we've had disaster. Now, has it saved lives? It's arguable. I think time is going to tell. It wasn't really designed to. It was designed to keep our healthcare delivery system from being overwhelmed. We've proven our healthcare delivery system is not going to be overwhelmed. I am convinced of that. So I think we should try to get back to some semblance of normal.
Gary, should we feel better that the health department is in charge of all these decisions as opposed to the governor? And are they, because that's the main thing. You've got these
they're not
different mission statements of different organizations, and
the health department does not have the say over the governor.
Okay.
The governor can decide who he wants to listen to, how much he wants to listen to, how much to politicize it, and is under no obligation so far to even disclose on what basis the decisions are being made.
So basically, we submit to the health department, and then the health department submits it to the governor as far
Yes.
as what's happening.
We submit it to the local health department. They submit it to the state health department. They submit it to the CDC. I mean, and health department is just shining in the sun. I mean, this is what they live for. They have huge amounts of money. They're adding large numbers of people. They're being given great resources.
Mm-hmm.
They have a lot of power right now.
And they have a different mission statement too than, it's the mission for no deaths, as opposed to, like you talked about, taking responsibility and accepting that there's risk in life.
Right. I don't really, we have not exercised a clear and comprehensive approach. And, until we can basically state what is our goal, it's hard to state, how we should be trying to get to that goal.
And I think I did see some studies from a couple of different places where, in actuality, the overall death thus far is lower this year than what we had in 2019 and 2018. Is that true?
No, I don't think that's going to pan out to be true. It's too early to tell. You're going to need larger numbers over a larger period of time. I think that I think it's relatively safe to say this is a real disease. This was a real pandemic. The number of people who are dying above baseline numbers are going to be higher. We are going to be able to show that an increased number of people have died. But I think it's a fraction of the number of deaths that are being touted. And I think it's a question of how were they living before?
Mm-hmm.
I mean, if you're taking people that were basically just right on the edge and this virus knocked them over the edge, it was the straw that broke the camel's back. And that's the virus that's at fault, not their hypertension, obesity, diabetes, and the 18 other things that they had wrong with them. And you're going to say, okay, it's COVID that's different. It's kicked them over the top. Then you're going to see an increased number of cases, and I think you will. And I specifically think you will in very isolated areas. When you look at New York City, clearly. When you look at Seattle, probably. When you look at Bellingham, not so much.
Thank you.
Okay, I am 5 minutes over. I'm going to officially call this to an end, but I'll stay online for a few more minutes if people want to ask questions. I will make the slides available both on our Facebook page and on the website so that you can go through the slides at your leisure. All that material pretty much came out of the state and county's Department of Health. And if you want to track stuff rather than listening to the news, they are tracking it. Now, a piece of bad news I have to share with you all is that up until about a week or so ago, there was much greater local transparency. The hospital was publishing every day the number of empty beds, the number of patients in the ICU, the number of patients on a ventilator, the number of people that were being admitted that had a positive test result, and everybody that was coming into the hospital was being tested. They have stopped doing that because, the importance of these dashboards has taken over whether or not we're going to be able to advance from phase 1 to phase 2 to phase 3. And so there is no independent source of data other than coming through the health department and the Department of Health that you can rely upon right now. And it just shocks the hell out of me every time I hear about there's new deaths when I hadn't heard anything about deaths. And when I call the hospital, house managers, it's like, oh yeah, that we did have a death, but that patient, was on hospice. Or we did have a death, but that patient, had a DNR, do not resuscitate order, and, was really sick. We're not segregating out patients dying with the disease from those dying from the disease. And it isn't an easy thing to do. Anybody else? Okay, let's bring it to a close. Thank you all for participating. I'll look forward to next month, which will also be an online Zoom. Currently scheduled is Doug Erickson to give us a legislative update and to give his opinion about what's going on at the state level. And should be interesting. And I'm available, stay tuned.